Hello, and welcome to the CAP Today webinar for Tuesday, December the 14th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session today after our formal presentations. Today's webinar is entitled Exploring Diagnostic and Antimicrobial Stewardship Interventions to Optimize Management of Gram-Negative Bacteremia. Today's webinar is made possible by a special educational grant from BioFire. I want to acknowledge them and thank them for their support for this very important program. We have two speakers today, and I'll say more about each one in due course. Our speakers are both from the University of Maryland. Dr. Kristie Johnson is the Medical Director of Microbiology and a professor at the University of Maryland School of Medicine. Dr. Kimberly Claeys is Associate Professor of Infectious Diseases in the Department of Pharmacy, Practice and Service, and she's with the University of Maryland School of Pharmacy, and she's a PharmD. Both, of course, at the University of Maryland in Baltimore, Maryland. But before we begin, I'd like to go through just a few housekeeping ideas and hints that will, I hope, enhance your enjoyment of today's program. We often suggest that you refresh your browser as we begin here. You will see on the lower right-hand corner of your computer screen, we have a 800 number for support at any time, 858-345-5916. We have live operators here to help you out if you have any technical issue. Also, you'll see below the slide deck a box labeled Q&A. You can make comments about any technical problems again there, and we'll have live staff available to help you. Of course, the Q&A box is chiefly there for you to ask your questions or make comments about the substance of today's topic and presentation. After the formal presentations have been given, we'll have a question and answer session and hope to get to all the questions and comments that you have for us today. I want you to know that the full audio and slides of today's presentation should be available to you for review in about a week, and that will be at our website, captodayonline.com. You should be aware that you're likely to get a follow-up email or two, so be alert. It's completely legit. And finally, as always, I have to note that CAP Today does not endorse any product or service that may be mentioned in today's webinar. Further, any comments that I make are purely personal, not to be taken as the policy of the CAP Today or the College of American Pathologists. And so now let us go ahead and begin. Our first speaker, as I mentioned, is Dr. Kristie Johnson. She's a PhD, a diplomat of the American Board of Medical Microbiology. She's a professor of pathology at the University of Maryland School of Medicine and the medical director of clinical microbiology at the University of Maryland Medical Center. We're delighted to have her, and I will invite her to begin her talk now. Dr. Johnson.
Thank you. Good afternoon, everyone. Move the slides, okay. I'm excited to be here today to talk to you about gram-negative bacteremia. Here are the disclosures for both myself and Dr. Claeys. Today we're going to discuss the available rapid diagnostic assays for positive blood cultures. We'll define how using a rapid molecular test can streamline your laboratory processes. We'll also describe the importance of the relationship between the clinical microbiology laboratory and antimicrobial stewardship to optimize the use of rapid molecular tests. And then we'll review methods to evaluate the rapid molecular tests from the laboratory and the antimicrobial stewardship perspective. And particularly, we're going to talk about a novel Doormat method. So again, today we're going to talk about blood cultures. I just wanted to go through the traditional blood culture workflow. So and talk about the time that it takes for us to be able to identify the organism causing the bloodstream infection and also to perform antimicrobial susceptibility testing. So if we start at time 0, and that's when the blood culture is drawn, it's sent to the lab. Depending on what happens in the hospital or where you're at, we try to do that as rapidly as possible, but there is data to say that the blood culture bottles can stay out for 24 hours. We put it on an automated instrument, and then that instrument detects the growth of the organism. And for true bacteremia, can usually routinely occur between 18 and 24 hours. We perform a gram stain and report that within an hour of the blood culture becoming positive, and then we have to plate it, perform bacterial or organism identification and susceptibility testing, which can take another 24 to 48 hours. So traditionally, this takes about 72 hours for us to be able to give a organism ID and susceptibility results. So in 2006, Kumar et al. Looked at survival of sepsis. And what they looked at was looking at survival with the time to appropriate antibiotics. So if you can see here, and let me see if I can get the pointer working. You can see here that with the time is along the bottom, so this is 0 to 0.5 hours, and then you have the percent of survival. So you can see that as a patient gets the appropriate antibiotic quicker, their survival rate increases. And so for them to be able to get the appropriate antibiotic in a timely manner, the laboratory needed to look at how we could decrease the turnaround time of bacterial identification or organism identification and susceptibility testing. So the laboratory in general has responded in many ways. So we've looked at identifying the organisms using mass spectrometry. We've looked at performing that on colonies after the positive blood culture has been plated and the organisms grow. There's also some data in the literature for performing that identification straight from the positive blood culture, and this is versus the traditional biochemical identifications that we've used. There's also molecular diagnostics. There's been single assays in the literature looking, for instance, for just one organism and a resistance marker, something like Staphylococcus aureus and your MEC-A, MEC-C. There's syndromic testing, or what we call multiplexed assays, in which you can detect multiple different bacteria and resistant mechanisms at the same time. That's really where Dr. Claeys and myself are going to focus on today. And then there's other methods in the literature where we're looking at rapid susceptibilities and also decrease in incubation. But again, we're going to focus on those syndromic testing today. So here, I don't know how difficult this is to see, but here are the blood culture identification molecular panels or syndromic panels that are on the market currently. And as you can see, I broke it down by your gram-positive organisms, your gram-negative organisms, and your fungal organisms. And I also put on there which resistant mechanisms. So you can see, if you look in these first two boxes here, this is the EPLEX BCID, then we have a Verigene and BioFire. BioFire has a BCID and a BCID2, and we'll go over that a little bit more within the talk, as that is those are the two assays that we compared in the Doormat analysis, and you can see that there's a mark where you can see the addition of organisms and resistant mechanisms within from BCID to BCID2. Some of these assays are specific by gram stain. So for your E-plex and your Verigene, you have a gram-positive assay or a gram-negative assay, and then for your BioFire, it's all one assay. Both gram-positive, gram-negative, and fungal are all in one assay. So when the laboratory wants to evaluate these rapid diagnostic tests, we look at different things. So we look at the on-panel organisms. So I just gave you a list. It might have been hard to read, but there was a list of what organisms that each of these assays could detect. So looking at those on-panel organisms and comparing that to your hospital or your laboratory, what organisms are found in your positive blood cultures. We look at your sensitivity and specificity of the assays. We look at the cost, right? So it's not just the cost of each assay individually, but the cost of the equipment. We look at space. How big is the instrument? Does it fit in the laboratory? The assays, how do we store them? Are they at room temperature? Do they have to be frozen or in the refrigerator? And then we also look at hands-on time. How long does the medical laboratory scientist spend setting up the assay, reporting the assay, et cetera? So when it comes to evaluating laboratory tests, we really sort of focus on your analytical and technical performance and our diagnostic accuracy. But really, a new concept, which isn't that new, came out about 10 or 15 years ago, is really taking a step further and looking at the clinical utility of laboratory tests. And this is really where a lot of the clinicians and laboratories are starting to focus on this clinical utility. And that clinical utility is really the degree in which the actual use of the corresponding test in the healthcare is associated with changing health outcomes. So we're really looking at this patient outcome. So, when we think about the analytical and technical performance, we look at this in the laboratory. This is really the ability of a device to correctly detect and measure the analyte in specified conditions. So we're looking at the limit of detection. We're looking at the accuracy, the precision, the range of an assay. And these are still very important to consider when looking at laboratory assays. We also look at the diagnostic accuracy. And again, that's the ability of a test to detect a condition when it's present or the absence of a condition. And really, we look at sensitivity, specificity, positive predictive value, negative predictive value. And now we want to take a step further and look at this clinical utility and really how a laboratory test will affect patient outcomes. And today we're going to look at one way for us to analyze the clinical utility of a test. So if we look at the literature and really look at the comparisons of rapid diagnostic platforms, we see a lot that are in vitro. And that's really focusing on the sensitivity and specificity of the on-panel targets. And it really gives you that limited insight into the assay. And an example of that, I just wanted to briefly discuss two papers that have recently been published in the literature, and that's the comparison of some of these rapid diagnostic tests that we're going to be talking about today. So the first one is a comparison of the GenMark E-plex and the BioFire BCID. And if you look and you focus on the gram-negatives, there was 100% sensitivity and specificity for each system. So if we look at these type of papers in the literature, it doesn't really help you decide because it looks like both of them are pretty good when it comes to gram-negatives, 100% sensitivity and specificity. And then in another study, if you looked at the BioFire BCID2 versus their first assay, which is BCID, again, you have 100% agreement. So how does a laboratory or a hospital or an antimicrobial stewardship program decide which one of these assays to bring to their laboratory. So when we look at clinical utility and patient outcomes, we have to look a little outside of the laboratory. And when it comes to positive blood cultures, we really look to our antimicrobial stewardship team or program. And that consists of an ID pharmacist, an ID physician, the microbiology laboratory, infection control, and your IT specialist. So if you look at the literature and look at clinical utility of these rapid diagnostic tests, one of the gold standards of looking at comparing the clinical utility would be a randomized trial. And here is the first randomized trial that was published when it came to rapid diagnostic testing and also rapid diagnostic testing with the utilization of an antimicrobial stewardship program. So this paper came out of the Mayo Clinic. They did a randomized trial of 617 patients, and they broke these patients into 3 arms that you can see here in the blue. So each one of these arms had approximately about 200 patients. You had the traditional arm, which was the traditional workup from a positive blood culture, which also included your AST or your antimicrobial susceptibility testing. Your second arm was a molecular diagnostic assay, as well as your susceptibility testing. With this molecular assay, they did have templated comments that were included with the results. And then the third arm was the rapid diagnostic test with susceptibility testing and templated comments, as well as real-time feedback. The primary outcome of this study was the duration of antimicrobial therapy. And they really were comparing antimicrobial utilization and patient outcomes within these 3 arms. And if you look at the chart that I have here, this is time from positive blood cultures and then the 3 arms. If you look, when you had a rapid diagnostic test, your organism ID was about 24 hours earlier, and so was antibiotic escalation based off of having a molecular diagnostic assay. Your susceptibility testing, which is in green, over here at 48 hours, you can see within all 3 arms this did not change. It still took 48 hours in which to have susceptibility testing. But what you can see in the third arm, when you add that real-time feedback with your antimicrobial stewardship program, you really see a decrease in antibiotic de-escalation. Then Tim Brook et al. Wanted to look at all of the data in the literature. And so his group did a systematic review. When they defined a rapid diagnostic test as any commercially available molecular assay that provided results in less than 24 hours, they looked at mortality risk with a stewardship team. They also looked at mortality risk by organism, time to effective therapy, and length of stay. So they did a literature review. They compared rapid diagnostic tests with antimicrobial stewardship and without antimicrobial stewardship programs. And if you can see here, what they found is that the rapid diagnostic tests were able to improve time to appropriate antibiotic therapy and to decrease all-cause mortality only when used in conjunction with antimicrobial stewardship team. So the papers that they reviewed without antimicrobial stewardship teams failed to demonstrate a significant decrease in mortality risk without the active stewardship team. I wanted to go over a little bit about what the lab needs to think about, or this antimicrobial stewardship team needs to think about before implementation. So there's things that the lab needs to think about, things outside the lab, and both. So when it comes to the laboratory and running these assays, think about, are you going to run them on all shifts? Are you open 24/7? Do you have enough staff to run this 24/7? To run them, which bottles are you going to run it on? Just the first positive, all bottles, run them only if the gram stain is different. What kind of storage requirements, which we talked about before for the assay, and then what identification methods that you're using to identify bacteria and susceptibility testing. When we think outside the lab, we really need to think about having physicians on board and the stewardship team on board, and they have to understand how to use it. I can tell you that we've spent a lot of time with our physicians on understanding the use of some of these tests. You need to think about your bacterial epidemiology. What organisms do you see in your blood cultures? What kind of contamination rates do you see? Does the assay need to be able to detect those organisms that you see in your contamination, and also your resistance, the resistive rate, antimicrobial resistance? And then something for both, again, how are these results reported and how are they interpreted? So it is interesting, at least in our case, to, we thought reporting it was very easy and we understood it. And then when the physicians got it, they interpreted it a little bit different, and we had to make some tweaks to make sure that the physicians were able to interpret the results correctly. Some of the barriers to implementing these tests are the cost to the laboratory. So you can't get away from the traditional blood culture. So you're not taking away any testing, you're adding to the testing. The equipment and test costs, again, the space requirements, what kind of technical complexity is needed to run the assay, how much of the technologist's time does it take. And again, talking to people outside the laboratory and really getting them to understand the kind of cost savings outside of the laboratory that a rapid identification assay can help with. And then really requires physician buy-in. So if physicians don't read the results or don't act on the results, then, it's not as helpful. And I think you could see that in both of the randomized trial I talked about, and as well as the systematic review, where if you have a rapid diagnostic test but without antimicrobial stewardship, the clinical utility isn't always seen. So today, we're going to focus on gram-negative bacteremia, or assays that detect gram-negative organisms in positive blood cultures. And here I just wanted to throw up some data so that you can see what type of organisms that we see, gram-negative organisms that we see in blood cultures. This is a recent publication looking at the adult central line associated bloodstream infections, and this is from the National Healthcare Safety Network. So this is data that hospitals in the U.S. report to the CDC. And so you can see here that the typical gram-negatives are the most detected gram-negatives that we see in central line associated bloodstream infections. You can see Klebsiella, E. coli, Enterobacter, Pseudomonas on the slide. So these are organisms that we should be thinking about being able to detect within positive blood culture assays. The data that I talked about when it comes to rapid diagnostic testing and antimicrobial stewardship, most of the data out there in the literature really focuses on gram-positive organisms that are causing bloodstream infections. the gram-negative rapid diagnostic tests have really been slower to be adopted both by laboratories and by antimicrobial stewardship teams. And the reason for that, there are multiple ones, but gram-negative organisms, I think, are a little bit more difficult. There's more genetic diversity in gram-negative organisms that are pathogenic. They have numerous and complex mechanisms of resistance. With the current rapid diagnostic tests that are out there, there's some incomplete data. There's some organisms that might not be on the assay. There might be some resistant mechanisms that aren't seen or detected on the assay. And that just makes some of the decisions for escalating or de-escalating a bit more difficult. And then also with some of these assays, there's known limitations and potential consequences, things like, again, resistant mechanisms that aren't on panel, and some of these organisms have very complex mechanisms of resistance, and then polymicrobial infections with gram-negatives can be difficult to detect. So I want to thank you for having me today. I'm going to turn it back over for Dr. Claeys.
Thank you very much, Dr. Johnson, for that wonderful and very comprehensive intro to our topic today. Let me just remind you briefly in the audience that at any time you can ask questions or make comments using the Q&A box below the slide deck. And I want to thank once again Dr. Johnson for a wonderful presentation. She'll be on for our question and answer session after our second and final presentation, which will be given by Dr. Kimberly C. She is a PharmD, Associate Professor of Infectious Diseases in the Department of Pharmacy Practice and Science at the University of Maryland School of Pharmacy. She did her PhD, or her PharmD and fellowship at Wayne State in Detroit, and she, of course, is currently at the University of Maryland School of Pharmacy in Baltimore, Maryland. Dr. Claeys, please begin.
Thank you for that introduction. Moving on, kind of segueing from Dr. Johnson's slides, we talked about the challenges for gram-negative bacteremia. I do want to talk a little bit about some of the data available to actually show the positive impact we can have in terms of gram-negative bacteremia with these molecular rapid diagnostic tests. So a couple studies here focused on implementing these RDTs for gram-negative BSIs only and the success we've had with them. The first study you see here, it's a pre-post implementation study from Cleveland Clinic Health System. It used centralized microbiological processing. During the implementation period, the RDT they used was Veregene BCGN, and it was run 24/7. Their stewardship intervention consisted of real-time clinical decision support to notify the pharmacist of the RDT results, and that occurred during regular working hours. After receiving the alert, the pharmacist would review the RDT results, review the patient's information, their antibiotic therapy, and then reach out to the primary team to notify them of the results and make any potential therapy recommendations. So the primary outcome of the study was time to antibiotic switch, and then secondary outcomes were time to antibiotic switch in the subgroup of patients on initial inappropriate therapy, and they also looked at some clinical outcomes as well, which we'll discuss on the next slide. So overall, looking at the pre versus post cohort, pre-RDT ASM implementation, what's interesting is, even among this large cohort, the proportion of antimicrobial switches remained the same between the pre and post groups, but it really was the time to switch that significantly decreased post-RDT implementation, again with that stewardship involvement. And the figure here really demonstrates those times, which are all statistically significant, but going through them, the median time to any antibiotic switch decreased by 15.5 hours, median time to escalation decreased by 13 hours, a little less impressive, the median time for de-escalation only decreased by 4.5 hours, but among those 195 patients who were on initial inappropriate empiric therapy, time to effective therapy decreased by 18.7 hours. Again, statistically significant. Looking at clinical outcomes, mortality was the same between the two groups, but they actually were able to demonstrate a decrease in hospital length of stay by a median of 2 days after the implementation of this rapid diagnostic with stewardship intervention. Looking at a kind of similar study with rapid diagnostic stewardship, rapid diagnostics and stewardship combined being implemented, another pre-post study. This one used 2 different rapid diagnostics in 2 different phases. First, they implemented the MALDI-TOF, and then in the second phase, they implemented the BioFire BCID, both of these with active stewardship intervention. So the stewardship intervention that occurred, very similar to the previous study, using real-time clinical decision support. The results of the RDTs were sent to stewardship pharmacists for interpretation and intervention, again, happening during normal working hours. In this study, the primary objective was the proportional difference in patients receiving appropriate empiric therapy. And secondary objectives included things like time to de-escalation from combo therapy, anti-sumal beta-lactam therapy, or carbapenem therapy. So overall, this was a pretty large study. We have over 1,000 participants, most of them being in the pre-group. However, we look at our post-RDT ASM implementation. The post-implementation phase 1 was 182 patients. Post-implementation phase 2 was 151 patients, giving us 330 total. After implementation of the RDTs, with stewardship involvement, they were able to show an increase in empiric therapy appropriateness that was statistically significant. Also statistically significant empiric decreases in empiric combination therapy and empiric anti-sumal mono combination therapy. There's no change, however, in the amount of carbapenems used. Looking at the graphic we have on here, this is the time to change from anti-pseudomonal therapy in the subgroup of patients that did not need pseudomonal therapy. And they did find a significant change. So between groups 1 and 2, there was a 60 to 80% proportional de-escalation from anti-pseudomonal therapy within 72 hours of the RDT results. And the majority of that did occur before traditional micro results were released. So they were able to implement and see change in the use of anti-pseudomonals in a timely fashion. So again, some positives when we look at using these tools with antimicrobial stewardship involvement. And to kind of further support that, there's been several studies recently that have shown that RDTs for bloodstream infections are cost-effective. The first one on the slide here, it looked at the cost-effectiveness of 7 different molecular RDTs, and the subcategories are kind of listed on the figure here that we can see. But what's interesting is molecular or multiplexed RDTs, in particular looking at gram-negatives with antimicrobial stewardship involvement, were one of the most cost-effective options. And also, these ones had an 80% probability of being cost-effective. That is with AST involvement. If you just had the molecular RDT implemented without AST involvement, without any stewardship interventions like we saw in the previous studies, the chance of being cost-effective drops to 40%. The second study here listed compared the cost-effectiveness of the BioFire BCID with conventional methods for identification, specifically in E. coli BSI. Again, they found that using the BioFire BCID resulted in cost effectiveness, decrease in cost, increase in quality of life years compared to conventional methods. They believe that the increased quality and decreased cost was really related to the decreased length of stay and cost per days of hospitalization by having these interventions implemented. So really, with studies like this that have come out, our thoughts about what we should be doing and our research towards this kind of moves away from should we be using these RDTs to aid in the management of BSIs, especially gram-negative BSIs. I think we can assume that even given the challenges that we face with them, there is benefit to be using them. The question really goes to which one should we be using to optimize the management of our BSIs, in particular gram-negative BSIs, at our institution. And given our infectious epidemiology, given our prescribing patterns, how do we optimize them? How do we make them work the best for us? And that segues into kind of comparing and contrasting the lab perspective from the stewardship perspective on these tools. So Dr. Johnson talks about considerations and barriers to implementation from the lab perspective. here's some considerations from a stewardship perspective, especially a stewardship pharmacy perspective. So for our perspective, the most important thing for the RDTs is how they impact antimicrobial therapy decisions, with the overall goal being how they affect clinical outcomes. And we know that different RDT panels detect different organisms and resistance mechanisms, so they should have downstream impact on the clinical therapy decisions. But again, as Dr. Johnson mentioned, assessments of in vitro sensitivity specificity don't really help us when we think about, well, our institutional prevalence of organisms and resistance mechanisms, our prescribing, our formulary, none of this has any context there. So again, most of that comparative literature doesn't really help us kind of nail down our questions about prescribing and outcomes. And we don't really get a sense of how these tools really impact that and how one tool compares to another. And that's why we started working on the publication we'll be spending most time talking about today, this study looking at comparing 3 commercially available RDT panels used for the management of gram-negative BSI, and looking at how we can compare their potential clinical utility using this Doormat analysis. And we looked at doing this as just a simple proof of concept study at the University of Maryland Medical Center of adult patients with at least 1 positive blood culture with a gram-negative rod. Patients were excluded if they had yeast or gram-positives, also isolated. They're excluded if the blood cultures came from outpatient facilities, if the cultures were repeated during the same hospitalization, or if they were discarded, the samples were discarded before additional molecular testing could be done. We compared 3 RDT panels. I'll show you in the next slide more details on those. And the primary objective was to evaluate potential differences in antimicrobial prescribing patterns based on the results of these RDT panels using this novel Doormat analysis. And again, I'll go into Doormat in immense detail on the next few slides. And then secondary objective to look at the on-panel positive percent agreement. So the 3 panels we compared were the Veregene BCGN, the BioFire BCID, and the new BioFire BCID2. And, briefly, as you can see on the screen, just going through them, the Veregene detects for the gram-negative side 8 organisms at the genus or species level and 6 resistance determinants, 1 for ESBLs, and the rest for carbapenemase production. The BioFire BCID detects 11 organisms, so more organisms, but it only detects KPC, so no ESBL detection at all there. The BCID2, compared to the BCID, however, it expands both in the number of organisms detected and on the resistance mechanisms detected. As you can see here, we've got ESBLs that are detected, carbapenemase detection, and even colistin resistance detection. So there are significant differences between these 3 panels and what they can detect and report out to the provider. Jumping back into our methods for the study, these are the microbiological techniques used during the study. These findings, similar to other studies that look at similar processing times, bacteria alert, gram stain, do the Veregene. The Veregene is part of our clinical study, and then final results, clinical practice at this time, so that's why it was included in the study. The VITEC2 and VITEC-MS were our final organism ID and susceptibility testing. The BioFire BCID and BCID2, which was RUO at the time, were performed on retained blood samples that were discarded from the micro lab. So I keep saying the word Doormat. What is Doormat? Well, Doormat basically is a way to help us compare these tools without having to do a full-blown randomized control trial. The Antimicrobial Resistance Leadership Group developed this methodology. It's entitled Desirability of Outcome Ranking, Approach for Management of Antimicrobial Therapy. So that's where that Doormat acronym comes from. And basically what it does is it provides a framework that's when you use it with a partial credit scoring system, that framework is used to compare potential antimicrobial choices in terms of their overall desirability based on the organism's final phenotypic susceptibility profile. That'll make more sense in the next coming slides. And it's important to note that prior to our work, Doormat had not been applied to compare rapid diagnostics. So going into the Doormat framework more, because the little elevator pitch doesn't really get to all the details, right? Both spectrum of activity of the antimicrobial and the resistance profile of the bacteria isolated plays a critical role in the consideration of desirability of antimicrobial therapy, correct? We want to be able to choose the antimicrobial that's most narrow in spectrum while still having in vitro activity, so allow best clinical outcomes while selecting for the least amount of development of resistance or selective pressure. There's several main steps to developing the Doormat. First, we want to look at defining our antimicrobials of interest and their spectrum of activity. Once we agree on the antimicrobials of interest and their spectrum, we rank them in an ordinal manner from most narrow to most broad. So an example, you can think of E. coli beta-lactams. You can go from cefazolin to ceftriaxone to piptazo to meropenem, all the way to Cas-Avi. And that could be your ordinal ranking from most narrow to most broad. Second step is to determine the possible organism resistance profiles based on antimicrobial spectrum levels. So you go from an organism that is pan-susceptible all the way to an organism that is resistant to everything but the agent of last resort. Step 3 is to actually create that matrix or that framework that cross-references these. So you can see you have your antimicrobial spectrum considerations that you've developed here, and your phenotypic resistance profiles you've developed here. And part 4 then becomes actually defining the partial credit scoring system to go with this framework. So you can see the different colors here are related to the partial credit scoring. The partial credit scoring goes from 0 to 100, 0 obviously being least desirable, 100 being most desirable. So 100 is going to be your most narrow, most effective therapy. 0 is going to be ineffective therapy. Anything in between, you can rank. You cannot rank a score different ways. So this is just an example. It doesn't have to be this way. Slight overtreatment and moderate overtreatment at 50 and 25 respectively. You can do these in different categories. You can have more categories. You can compare scores between them. But that's basically a setup for it. As long as there's between 100 and 0, we have some kind of scoring system set up. And lastly, it's important to consider, I gave the example of E. coli. If you're looking at something like this where you're doing multiple different organisms, you need to have a matrix for each organism. So how do we go on and apply these matrices? Well, first we start with the clinical scenario of the patient. When you're making antimicrobial therapy decisions, you're not making them in a void. So you think about the type of patients, whether or not they're in the ICU, their acuity, the source of the infection, their allergies, their prior history of MDRs, and their previous antibiotic exposure. You have all those in your mind when you're making a decision. You take that into consideration as well as, your local infectious diseases epidemiology through your antibiogram, your formulary, your typical prescribing patterns at your hospital. And if you have it, like for us, we have an RDT treatment algorithm kind of already built to help guide therapy decisions. Given those considerations, you're provided with the 3 different RDT results here from BioFire, Verigene, and BioFire BCID2. Based on those results, you are now going to have to make a therapy decision. So based on those results, we could say these are the therapy decisions that were made. So it's CTXM negative, we de-escalate the ceftriaxone, we just have E. coli, we don't really know if it's CTXM positive or negative, we might keep them on our workhorse agent and wait for final susceptibilities. BCID2 is very similar to Verigene with results negative to ceftriaxone. What happens then is after we've made that decision in the context of all this other known information, we actually go ahead and look at what the final organism susceptibility profile was. So this E. coli was a pan-susceptible organism. So if we're looking at our Doormat matrix, it would fit under this category of pan-susceptible. And based on our local prescribing patterns, we've got optimal and intermediate 1 in our matrix, but you can see intermediate 1, ceftriaxone, is still going to be given an optimal score for E. coli in these situations based on our partial credit scoring system. So for Verigene and BioFire BCID2, we give it both a score of 100. Because we stuck with just piptazo because we weren't sure about any molecular resistance, we give it a score of 50 because it fits into our intermediate category 2, which we've defined as slight overtreatment. If for some reason this patient maybe had been in the ICU or maybe had a prior MDR, that might have triggered someone to choose Mero instead of piptazo. That would still go into this broad category, moderate overtreatment, and that score would be 25. So that's kind of a working idea of how this works through. And then you just rinse and repeat throughout each case, and what the RDT results are for each case, getting the scores for each RDT, getting the average and the standard deviation of that. So the methodology is a little bit more complex and a little bit more novel, but the statistical analysis behind it is pretty simple. We did positive percent agreement as well, which I think everyone's pretty familiar with. It was with the positive percent agreement with the Vitek MS. It's listed here on the screen. And then interesting with the Doormat, and I think important to note, is the Doormat scores need to be presented as means with standard deviation, and we used a paired t-test to compare them. And the reason that we kind of ignore the normality assumption here is because if you use non-parametric tests, you revert back to rank, so they'd no longer be scores. Otherwise, the statistical tests here are very simple, just paired t-tests. So let's look at the results of this paper. There's 108 gram-negative organisms isolated from 103 patients, primarily urinary sources, almost half of them in the ICU. Not surprising, on-panel positive percent agreement between all three panels was both high and very consistent. So not a lot of insight when you're looking at on-panel organism agreement. What is interesting, though, is when you look at what's not detected on each panel. So of the organisms, of the 108 organisms that were detected, these were the results from the final Vitek MS. Verogen did not detect 25 of them. BCID did not detect 16 of them, and BCID2 did not detect 9 of them. So the big take-home there then becomes that the BioFire BCID detected 60% of the organisms not on the Verogen panel and 24% not on the BioFire BCID panel. And just as a little aside, we only had 6 ESBLs in this cohort, CTXM positive. Both the Verogen and the BioFire BCID2 accurately identified all of them. Now looking at our Doormat results here, the mean Doormat scores are listed here for the Verogen, BioFire BCID, and BioFire BCID2. You can see that the Verogen and BCID2 are in the 80s, the BCID is in the 60s with a higher standard deviation. You can kind of see from the graph that this is likely more due to a lot more moderate overtreatment as opposed to slight overtreatment and a little bit more ineffective treatments here. And what's interesting is when you compare across all three Doormat scores, there's a significant difference across the panels. The mean score was significantly higher for the BCID2 versus the BCID when you do a two-way comparison and adjust for that comparison. And it was very close for the Verogen, but I think that's a lot that has to do with our limited sample size. But again, this can give you an idea, based on the therapy decisions that are going to be made from these results, whether or not you're going to have actual changes in your prescribing patterns. And it doesn't get you all the way to clinical outcomes, obviously, and this isn't a full randomized RCT where decisions are being made and outcomes are occurring, but it gives you insight that you would not have if you just did a typical in vitro test comparison. So with that, the conclusions are that all the platforms, again, had high level of agreement for on-panel targets. The off-panel targets varied differently, and you can see the BioFire BCID2 detected many that were not on the other two panels. And through Doormat, we demonstrated that these in vitro differences may also have a clinical benefit in terms of antimicrobial prescribing decisions. And I think with that, I just wanted to acknowledge everyone that worked on this project and thank our Society of SIDP Research Awards for helping us with the funding. And then with that, we'll take any questions.
Dr. Claeys, thank you so much. That's an excellent presentation. In fact, I think this tandem and team approach of talking about the diagnostic side along with the antimicrobial stewardship side is really very enlightening and intriguing. And in particular, you've got a wonderful publication there that I'm sure many, many people will like to review and think about. We have only a few minutes left. Let me invite anyone in the audience who'd like to make a comment or ask a question to type one in at this time. I'm going to start, though, with a question for both speakers, which is many people in laboratories are very interested in helping to justify the acquisition of new technology, such as you've described today. And I know that many people in pharmacies are very anxious to be at the very top of the curve in terms of antimicrobial stewardship. And you seem to have achieved at Maryland a very, very good partnership. So my question for you, and I'll start with Dr. Johnson and then go to Dr. Claeys. Do you have some tips for anyone in the audience who's seeking to have such a good pairing and a good team approach to these questions of rapid testing and antimicrobial susceptibility? In other words, how does this work? What does the lab need to do to optimize working with pharmacy and vice versa? Like I say, Dr. Johnson, would you like to take a stab at that very general question?
Sure. I mean, I think it's really important to have communication, to meet. We meet on a weekly basis sometimes and just sort of discuss, the priorities for both the laboratory and for the stewardship, and sort of to understand the issues that both teams have. And I think that we do a good job here at Maryland communicating and sort of trying to understand the barriers that each group has and to work with those to move forward. I mean, because in the end, we both want the same outcome.
Very good. Dr. Claeys, would you care to comment on my question?
Yeah, I think this is kind of why I threw, the term diagnostic stewardship in there, because these working with the lab is going to be so much more impactful for some things than trying to catch them and change them on the back end through usual stewardship or post-prescription review, right? Like, being able to work with the lab and decide through the continuum of the testing and the reporting how everything's going to come out, what it's going to look like, will help us determine kind of and shift, hopefully, to more better describing decisions, shift those antimicrobial describing decisions to a more positive way, helping maybe decrease inappropriately broad therapy, or sometimes some of the projects we've worked on is making sure we have those different highly resistant organisms, have the newer agents tested for them as soon as possible. These are just the things that we kind of work on together, realizing that we are part of this continuum that goes from when the sample gets sent down all the way to when the provider reads that report and makes that therapy decision, to when stewardship pharmacy sees it a day or two later to try and act on it then. So I think that's one of the things that I always go into, is thinking that if we work as a team, we can adjust along this entire spectrum to help improve patient care.
Thank you. And tell me, Dr. Johnson, how has this been received by the infectious disease doctors at the University of Maryland?
Yeah, so I think it's been received really well. I mentioned that we've done some education. So we've actually switched from one platform to another. And we've also switched from the way we report things. So with the first time we had a rapid diagnostic assay in the lab interpreted the result and would report it in the into the blood culture report. Now we actually report out each organism, if it was detected or not detected. Our infectious disease group, they really like this. They know the result's going to be there. They're always looking for it. And we have worked with them to make it easy for them to understand the results. And with Kim and the stewardship group, we've actually made algorithms based on what's detected in these assays on what type of therapy they should be considering. So our ID group has really enjoyed it.
Very good. Dr. Claeys, would you like to add some comments or color comments around the ID group or other prescribing physicians that you're working with in Maryland?
Yeah, I think we also do, from a stewardship standpoint, review the results of the RDTs. Similar to the studies that I presented on, we do those reviews and reach out to providers as well, and usually, quite often, that's met with very positive feedback, because sometimes they might not have seen the result already, or if it's not being followed by ID, they might not have really, even though we try to assist in interpretation, these things are confusing. You know, we have a CTXM positive or a KPC positive. Sometimes they don't know exactly what that means, and then having us reach out to help assist with that is usually received very well. And I think from our ID colleagues from the physician side, they do respect that we are there helping them with these technologies and being a liaison with the microlab.
Thank you. And let me just ask you one more follow-up, Dr. Claeys. I realize, of course, that the antimicrobial stewardship is really a clinical matter, and it's essential to optimal patient care. But do you have some plans as well to look at the overall savings in antimicrobials, some of which, as you well know, get to be very expensive? Will that be a subsequent area of investigation for your team?
That is a great question. I will say that I am not great personally at that type of research, but I would be interested in it, because as you saw from the two cost-effectiveness studies that we demonstrated, that we presented on, it is cost-effective, and a lot of it has to do not so much with changes in antimicrobial costs, because realistically, the cost of one antimicrobial to another, unless you're probably going, if you're doing it right and you're escalating therapy in those patients that need it, you can be adding costs, right? But that improves patient outcomes. And the cost of switching between a cefepime and a piptazo probably isn't a lot of money. The money really is looking at decreasing the hospital days and expenses, decreasing ICU bed days and things like that. So I do think there is something there. We haven't done it particularly ourselves, because I think we found compelling data outside of us, and also just because I don't know how to do cost-effectiveness research.
I understand. That's a wonderful answer. That's very good. And Dr. Johnson, let me ask you a question. We all know in the laboratory world it's often very difficult to justify new technologies. Have you found that the work that you're reporting on here has enabled you and helped you to justify new technologies as they come into the lab, and given you perhaps a model for some future new technologies that you'd be looking to add to your lab mix?
Yeah, so I've been performing research in this area for a while, starting with some of the older methods like probe technology, PNA fish technology, and we've been lucky to have some of that data in our laboratory, and our administration has really looked at that. We did have some data on cost savings of antimicrobials, mainly antifungals, and they looked at that data, they saw that the data worked in our hospital, and now it's easier to show them the literature and sort of justify the decisions that we're making, since they have seen that same data within our hospital. So I do believe that our administration really looks at not just the laboratory costs, but look at what's happening and, on the hospital side, the patient outcomes, the length of stay, the mortality. And so it's easier to justify some of these new technologies with this type of data.
Thank you very much. And with that, I'm going to give you the last word, Dr. Johnson, and begin to wrap up here. I think we've had a very, very stimulating webinar today on a very important issue, and I think should be suggestive of future efforts on the part of both pharmacies and clinical labs, which is a wonderful idea. So let me wrap up. I want to thank Dr. Kristie Johnson, the Medical Director of Microbiology at the University of Maryland Medical Center. And of course, I want to thank Dr. Kimberly Claeys, PharmD, in the Department of Pharmacy, Practice and Science, Associate Professor of Infectious Diseases, again, the University of Maryland. I also want to thank BioFire for their special educational grant that's made today's webinar possible. We're always grateful to them for that chance. And finally, I want to thank all of you who've joined us today. I'm very, very grateful that you've done that. I know how busy you are, and we are at the end of the year, and so I just want to thank you all for your attention today. So finally, to wrap up, thanks to Dr. Johnson, Claeys, BioFire, and all of you. And with that, I will bring today's webinar to a close. Thank you.